The disclosures, we discuss particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. We love every ventilator. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic's. I do receive fees and royalties from books, chapters, and lectures, and along with Rob, we own a patent. We don't ever discuss that here, but we're happy to. And Rob is a consultant from IGMAR and all these companies that you see there. The ground rules, remember, this is a recorded session, so just keep your microphone muted. The moderator may call upon members of the audience to comment, so use your chat function. If we see a comment on the chat function, we may ask you to explain this a little bit better to us, or to comment on what's going on the slides. And again, this is an exercise on seeing these graphs, these waveforms. I get them from everywhere, and then once that we get them, we sit here and try to go through them. Some of them are pretty complex, some of them are relatively easier, but the goal is that we all learn and try to understand what the ventilator is doing with our patient. I see Rob is on the line, so hello, Rob. There you go. Okay, so this is the first one. This is a courtesy of Satish Chandra from Twitter. Sent it to me. He sent me 2 images. I kept one because I think it shows exactly the same as the other one, but it's a good one to go over it. So I'll ask either my respiratory therapist or my fellows if they want to read it out loud. Again, you'll be as right as anybody else as we're going through this. So please, any volunteers from our fellows? Or therapists? Okay. All right, let's do it. Rob, you and I will go over this. So what's the tag? So let's take a look at this for a second. This is an interesting waveform. It says pressure control, and it's auto mode, and you have a breath that is triggered by the machine, so that immediately makes it a CMB. And we see the pressure is controlled throughout the breath, actually. And there's this the flow is not a geometric shape. Actually, it doesn't look like perhaps sinusoidal, just reflecting the effort of the patient. And so I would say this is pressure control and CMB. And then the targeting scheme, just with one breath, it's hard for me to say if there's anything, but just knowing this ventilator, this would be set point. Rob, any comments here?
Not so far as the control variable, no.
No. I when I was looking at this, it caught my attention. A couple of items that we're going to talk about is obviously the rise time, and obviously this is an I time that goes for a fair amount of time, goes 1 second, 2 seconds, essentially 3 seconds of inspiratory time. So it's pretty prolonged in general, and the rate is low with a low amount of support, which I presume that there was an attempt to try to deal with this patient's breathing pattern and trying to help with that. So, but that would be the tag. In terms of the load, this is a beautiful one because the patient gets up, the system pressurizes, and actually it takes some time. Normally we would have expected this to rise immediately up and come like that, and instead of that, it takes a fair amount of time to rise. So, which tells me that the rise time is set low. So they instead of having an immediate rise time, so 0 milliseconds, they added time to the rise time so that it takes some time to get there. So it pressurizes the system, but there's actually absolutely no change in flow throughout the breath. And actually, you can see also on the volume waveform, there is no change. So there's a breath, but no air moving into the patient. Absolutely none. So I cannot read the mechanics here. It could be a very high resistance, or it could be a high elastic load, or simply there's a lot of PMOS. The patient is tense, not wanting the breath to go in. I don't know. I mean, there's no flow movement. So, and then comes the PMOS, and throughout the breath, there's a big amount of PMOS throughout it. So in inspiration, the only thing that I can read is the presence of PMOS during that period where the patient is taking a breath, and then the patient exhales. And the key point here is that it doesn't decay exponentially, but it continues for a fair amount of time, not reaching baseline. And because it doesn't reach baseline, but it doesn't have that nice decay that we would expect, it makes me think that actually what I'm seeing is again PMOS, that the patient is actively trying to exhale here. This could be confused with the presence of resistive load. Perhaps the patient has an increased resistive load, because if he's doing all this effort and not getting the flow out, but because it's not an exponential decay, it makes me think that this is all this area that I'm shading is PMOS. Rob?
Yeah, and also look at how large the tidal volume is.
Mm-hmm.
Generally, that would provide a very high driving pressure for exhalation, but the peak expiratory flow is very low.
Right. So that makes you also concerned for a resistive load. Is that what you're saying, Rob?
Yeah, either that or it's somehow being distorted by the inspiratory effort spilling over into the expiratory time.
Okay. Very good. Thank you, Rob. Any other comments, Rob, here?
Nope.
Okay. Again, from the fellows and the teams on the line, if you have questions or comments and you want to share, just type them out and we'll address them. So let's go on to the patient ventilator discordance. And so there's PMOS, so there must be a patient ventilator discordance. If there was no PMOS, there would not be. So let's talk about the trigger. There's only one single breath here that I can see evidence of, and it's this evidence of this patient effort right here. So that this is the from here to here, there's evidence of PMOS. And then there's the ventilator triggers all the way over here. So because the reference is the patient, the ventilator triggered earlier than the patient. And so just by definition, this would be an early trigger. And this week in Twitter, I got in late on it, but there was a large amount of the of discussion about what was an early trigger, if it was the reflex of the ventilator of the patient when the pressure goes in and the volume goes in, or if it's entrainment, which one is which. And I frankly, at this point, I can cite what it's out there described, but I cannot necessarily physiopathologically say which one is which. But this would be an early trigger just by definition, the etiology of which we can discuss further, but just by the way that it's looking, it's an early trigger. I don't see any other one. Rob, do you see any concerns?
Yeah.
Then during inspiration, this would be actually work shifting, although it's minimal work shifting. The pressure is barely distorted on this ventilator, but the tidal volume is larger because the patient is doing the work on top of this. So there's more work. The patient is doing more percentage of that work. So this falls into our description of what work shifting would be. But I would not call it severe. I would call it just work shifting in general. That doesn't mean that it needs to be addressed. It's just something to be aware of. In terms of cycle, actually, the cycle is not terrible. I don't see major evidence of PMOS, meaning that the patient is trying to inhale and then that was terrible, like this. It doesn't look like that. There's a little bit of decay on this, but I would probably say that either by luck or happiness, this looks like a normal normal cycle. And then expiratory, I would say there's expiratory work. Rob, comments, concerns?
You know, there could be an argument that this patient is making a fairly large effort. We see flow from the patient, from the PMUS going virtually clear into the point of cycling, large tidal volume. And, you know, if you were to draw a PMUS waveform on that flow curve, I think it would spill over and clip off the peak expiratory flow.
Yeah, I actually I pushed it. If you notice my little high quality line, I tried to push it a little bit into it because I agree with you. If the patient would not have cycled there, this would have gone
Yeah,
like that, something like that, right?
yeah, I think so. Yeah, I think that's why the peak expiratory flow is smaller than you would expect.
Fair enough. Fair enough. Alrighty. So I'm moving it to early cycle, although this is an early cycle by luck, I would say, because actually there's another. If the patient had done the same PMOS and had started with a ventilator, it would have been a late cycle, right? It would
Yeah,
have taken a long time for it to cycle. So this is serendipity, I would say, in many ways. So when I saw, so that's how I would read this waveform. The first thought when I was looking at the oxygen concentration, the amount of PEEP, the respiratory rate, the size of the tidal volume, it made me think of somebody that had neurological injury and was coming out of deep sedation and was still toxic and had their own respiratory rate. And the team is there trying to figure out how to synchronize this, and all their attempts just lead to sadness. Um, that's what looked like to me, being very challenging to achieve something like this. And this happens very often. I mean, relatively often with brain injury. But I know I hope Satish is on the line and he can illuminate us if he knows a little bit more about this patient, um, so that we can put more context into it. Yeah, so that's right, Juan Martin. So that's why we placed an early trigger equals reverse trigger. And the other image that we posted on Twitter that Satish sent actually shows the next breath being triggered by the PMOS. It seemed to me that it was just entrainment, that it was out of phase, and that they were trying to do their best with the respiratory rate to achieve that, and that they couldn't achieve it. But yeah, see, if you by reverse trigger you mean this is a reflex to the positive pressure. I don't know. Actually, when I was looking at this and I saw the absence of change of volume here, it made me think that this patient was actively exhaling, the ventilator pressurized, and because the patient is actively exhaling, he doesn't get any breath in. So he was exhaling. He's one of those patients that take a deep breath in and then they go.
but if he was exhaling, why wouldn't you see an expiratory flow?
I think that that actually this is the next case. It's actually very nice. Well, for one, you actually I think that the flow is changing because look at the pressure, at the volume, Rob. It's just a matter of scale. I think that he continues to exhale, 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 and I mean he may be obstructed or not. But there has to be, for him not to get anything, either he has the most stiff lung in the universe and those 10 centimeters of water did nothing, or he is biting the tube, or he is exhaling against, or actively, the expiratory muscles are all active and not letting air in, right? It has to be
It
very
looks
high.
more like an occlusion, like you said. I mean, to have zero flow at the end of exhalation, or at the beginning of inspiration. I mean, that's an incredibly difficult balancing act to do with your PMUS. It just seems like it looks like he's biting on the tube and then letting off.
Yes, the thing that caught me off, that's I kept vacillating between those two, was that the volume kept changing.
Well, the volume is almost flat though. It's again, it's a scale problem probably.
Exactly. I
But
mean, he was coming from 1200
the
cc's.
volume is not, he's not exhaling as much volume as he inhaled.
Yeah.
So it appears that it's almost a flat line on the volume, which would give you a zero flow, right?
Yeah. Oh, so here it goes. So Satish, who was taking care of the patient, said expiratory muscles were active during the mandatory breath, and expiratory muscle relaxation occurred during mid-inspiration. So,
Yeah.
yeah. All righty. A good one. Interesting. I would just highlight here the rise time. I still have no good reason why we would put the rise time lower than in a mandatory breath. I'm having challenges figuring that why we would change the rise time. Any good idea there, Rob, or anybody else? Why would you guys
I've never
change?
seen a good reason to do that, particularly for a mandatory breath like that. The rise time should be as low as possible.
So if anybody has a good or why in your practice do you change the rise time? I would be interested in hearing, or if you want to type it in, that would be an interesting learning moment for us. Alrighty.
Can I make a quick comment or maybe ask a question? I don't have the answer to the rise time, and it still drives me crazy personally. But with regards to kind of labeling this as early trigger, if we would have assumed that the patient was biting, which isn't the case here now, knowing the bedside information, would you say that you wouldn't be able to confidently say it's early trigger in the sense of maybe the reason why we're not seeing flow, if the patient was biting, there was no flow at the start. I can't really tell if the patient would have been, like if I would have seen PMS or not with that inspiratory flow that I just can't see because the tube is obstructed. I don't know. I mean, I do understand why this pattern here is labeled as reverse triggering, but I wonder if the reason for the pattern would have been something different than reverse triggering if it was biting. You know what I mean? And I don't know if you can inhale while you're biting at the same time. Like they seem like two things that are opposite to each other, which maybe if you're biting through the start of inspirations and by default you're not trying to inhale, then it is a reverse trigger.
So I love that question because actually it gives an opportunity for explaining this a little bit better. When we talk about early trigger or late trigger, we're talking about what we see, a description of the pattern of what you see there. You're seeing a mandatory breath followed by evidence of PMOS. The mechanism, the etiology of it is varied, as you have said. It can be entrainment, it can be a reflex, as you would want to call classically a reversed trigger. It can be exactly what you just said. It just simply happened by chance at that moment. And that actually, if you ever sit down in front of as you have in front of a ventilator, you're going to see that sometimes we come and bother the patient and he takes a breath in, and it has nothing to do with a reverse trigger, but it happened with the pattern that would be recognized as a reverse trigger. And so I think that there's multiple etiologies for this pattern of early trigger, one of which is reverse trigger. The same thing for late cycle. It's not always an issue of we set the eye time too long for that patient. There may be etiologies for that cause that pattern that you see. Does that make sense, Ahmed? And that's why I move away from reverse. We move away from reverse trigger as a term, and rather because it's a mechanistic term, rather to a descriptive term.
It does. Thank you.
No problem. Excellent question, and thank you for bringing it up. I think I'm more inclined towards expiratory muscle activation, as Satish is saying, and the device breathing against him. So now let's see another case. Actually, that's why this series is called like that. And I'll ask, is there any fellow that wants to do the next one? Actually, I know I see here that Chris, Garab, Mariam are all in the fellows room, so we will never know who was answering. But do you guys want to try to tackle it as a group? Are you up for it? Did you run away? See, you can unmute yourselves, guys. Alrighty. So you can take a look at this. This was a really nice waveform that was sent courtesy of Serka Wadud, who's a fellow. And she sent me this waveform. She sent me a bunch of them, but I chose these ones because I thought that they talked probably to us, breaths without air. All right. It says that they're calling in. So we'll see if they if we get it. In the meantime, anybody else wants to start with the tag? Just by looking at this. All right, Tim Howell, thank you very much. So the readout from the team was PC-CMBS, and so that means pressure control, and I will absolutely agree with you guys. And these breaths look to be pressure throughout controlled, and you can see actually how the flow is different between each one of them. So it's definitely pressure control. We agree with that. In terms of the sequence, we also agree that this is a mandatory breath. Every single one of them. Not only are they this. Are you guys there, Marina?
Yeah, I just got us on. Sorry, we're here.
Oh, thank you. So all the I times are the same, and this is likely set point, because at least on this ventilator, the other alternative for this would be BC plus, and I will ask the team what would happen, what we would expect to see if this was BC plus on this sequence of breath. So set point versus adaptive.
What's the different tidal volumes?
You're right. You changes in tidal volume in between the breaths.
No, I don't think it's adaptive set point, because adaptive would give you like same tidal volumes roughly. I think it's set point.
Pressure,
So it's set point. If it was adaptive, what you would expect to see on the waveforms?
You would see some variation in the pressure required to get the volumes in between the breaths. They would not be identical like they are here.
So let's assume that the tidal volume that is set is this was good, right? So let's say that this tidal volume was a happy one. So in the next breath, what would happen to the inspiratory pressure? If this was a good tidal breath, the pressure should remain the same, right? Because this one was a happy one, but this one, the tidal volume is actually very low. So sad face. So the next breath, how should the pressure be? Up or down? Have no fear. Up. Thank you, Tim. So the next pressure, this would go up, right? And in the next breath, because this didn't achieve the tidal volume, in the next breath, you would actually have an even higher pressure to try to achieve that. So you would see, if this was adaptive, you would see the pressure starting go up, up, up to try to achieve the tidal volume that you're going after. Make sense? All right. Great job, Tim. All righty. So now, what's the load? What's the load? Anybody wants to give me what's the inspiratory load? You can type it on the chat if you want. So during inspiration, so I hear PMOS, and then there's some resistive, some PMOS. This is a good one because actually you have a couple. So in this one, you see evidence of PMOS, and we know that that's PMOS because it doesn't decay nicely, right? So all of this is PMOS. And in the last one, you again see the same thing. Actually, this is a nice breath to discuss a little bit afterwards, but that's all PMOS. So PMOS on the first one. And what about these ones over here? I'm just gonna name them 1, 2, 3, and this is the fourth breath. What's the main load in 2 and 3? Yeah, this is a tricky one. So I have some elastic. Alrighty, Rob, what's your determination here?
I would say it's P must, but it's in the expiratory direction, not the inspiratory direction. So it's like a negative P must, not a positive P must.
Right. So the patient is trying to exhale. Actually, you can see the flow actually crossed below the baseline, but in general, this patient seems to he gets a very little breath, and it's again a breath in which there's essentially no air movement on this patient. So it makes me think it's behaving as if it was elastic, but it's all PMOS. So it's all expiratory activity on this patient. So it's tight, similar to what we were seeing on the other one, in which you see very high impedance on this patient, and it doesn't let the flow go into the patient. So I would say that this is a PMOS event in which there's a lot of activity there. So let's really good. These are a good discussion. So let's talk about the trigger. In the first one, the trigger. And so this type of waveform can also be seen when the ET tube is completely blocked. Yes, Satish, that's correct. When the tube doesn't want any, when you crimp the tube, you're not gonna get any air in or out. You're gonna only see the circuit compliance, moving air in and out.
Dr. Morales.
Yes.
Quick observation / question. So the expiratory phase of the first breath, would you say it's mostly passive, or you think there's a lot of expiratory PMOS there right before the second breath? Because I think it looks more passive, because if you're thinking that's expiratory muscle causing these issues.
Yeah, that's a great question. Rob, what are you thinking here?
Well, it starts off looking like it's exponential, but then it sort of flattens out. So you have like a constant expiratory flow. And then the ventilator wants to, tries to cycle, tries to trigger, and the patient apparently is continuing to breathe out for the next 2 or 3 seconds. Yeah, the next 3 seconds, he's still trying to breathe out forcefully enough that the ventilator cannot cause the flow to substantially go above zero.
Yeah,
Yeah.
I think that you're so one of the challenges that I have with this, Rob, is and this ventilator does exactly what we described this time ago. I would expect the patient to be able to exhale during this period of time, right? If this is active exhalation, so that they get the breath, and then he would be able. I mean, there's some negative flow down here, and then it ends, and I cannot see anything else. So I don't know if this is PMOS or the other thing that comes again is the patient biting the tube again? Is this a manifestation of a tube bite? Because the flow changes rapidly, but something is obstructing, impeding the flow in and out of that tube. Can it be PMOS or it could be something else? Thoughts?
Well,
Yeah.
you know, given that the patient already has an expiratory PMUS, then the inspiratory pressure from the ventilator would have to exceed that to cause expiratory flow. So it's sort of like those two pressures are balancing, more or less, oscillating around zero during the preset inspiratory time.
Excellent. I like
It
that.
still looks to me like a patient is bearing down with their expiratory muscles rather than biting. Although you can't really tell. How can you tell?
It's hard. Alrighty. Very good. So this is again. Let's go to trigger for a second. So the first one, I would say that the trigger looks normal, unless anybody says otherwise. But there's a little bit of a dip of the pressure. It looks great. This is a mechanical breath, so mandatory breath. There is no real evidence of inspiratory effort. Yes, Imran, the patient can generate as much PMOS to completely stop the flow in and out, without a doubt. Remember that the amount of pressure that the ventilator delivers, you can easily overcome that by PMOS. Not easily, but you can generate more than the ventilator does. And if you deliver the same amount than the ventilator is trying to deliver, you will not. There will be no flow. Where I was. Oh, so this one is mandatory, no evidence of PMOS. But this one over here, again, the same thing. There's a mandatory breath. There's no evidence of PMOS. So this is a mandatory breath, followed by a patient breath, and so it would fall into an early trigger characteristic. And you can argue with me, and this is a perfect one, of saying, well, is this really early? Is this reverse trigger? And I would say probably not. This is just a difference on respiratory rate from a patient that just similar to the prior patient. There's different rates, the ventilator and the machine, and they are off sync at times. In inspiration, we talked, this looks like work shifting in the two that are present. The cycle on this one looks normal. The cycle on this one looks early because it actually triggers. There's evidence of another breath that got triggered over here. But we only describe the early triggers. So in general, I would say that this is essentially normal for this breath, and this one I would not rate because it's already early cycle, early trigger. And then expiratory, we said expiratory work as a potential etiology of what's happening here. Rob, any other comments? Corrections?
Now, that last breath, it looks like the patient hasn't inhaled for about 4 or 5 seconds, and now, when he's finally done trying to exhale, he takes a big, huge inspiration, which is off the chart. You can't see it.
Yeah.
It could have maybe triggered this thing 2 or 3 times, right?
Mm-hmm.
That would have been interesting to see if the time scale was more to the right.
And again, this would be I don't know if Circa is on the line. I don't see her, but this would be again similar to the prior patient, the patients that have neurological injury or patients that have issues with toxicity. So ways to resolve this, great question. So it's usually thinking what is the cause of it, because it's a neurological etiology of what's happening here. It's the respiratory centers are sending their rate and the size of the tidal volume at a given speed, and something has to be affecting the respiratory centers. So it's either toxicity from medications that we have given, or ischemia or inflammation after a neurological event. This is when I most often see this type of breathing. You don't see this in around the meal critical illness unless it has affected the respiratory centers. So good question, Ryan. So if I had a patient like this and you're trying to ventilate him, I mean, and this may be as good as it gets, meaning he's getting you're following, you set a rate and just be sad, or you put him on pressure support and hope that you set an alarm for a minimum minute ventilation and be sure that he's getting it, while the evident injury to the brain resolves. Those are things that I can think of. I would ask any other comments, questions, disagreements, anger management.
Just curious, why does the vent read the I/E ratio really off as it is? Is it basing it on flow, or because like if you base it off the pressure waveform, it's obviously not 5.9 to 1.
That's a great question. The only thing that I can say is that one of the things that you will learn from the mechanical ventilators is that what they measure varies from ventilator to ventilator. They're not consistent on what they're saying. So it could be that the breath that they're grading, this I/E ratio, is this last breath in which you have the early trigger. And so this is the I time, and then the E time is this little snippet of time. So it's 1 to essentially 6, the size of this one. And that's what it's grading for this single breath that you see here.
I think that's true. And in general, a ventilator calculates I time and E time by the zero crossings of the flow.
So it would be from this point.
1 0 crossing, and then right there is the next. So
Yeah.
that's all inspiratory time, and then the next one is there, and that's all expiratory time. So it's clearly, 5, 6 to 1.
But that does bring a important point, which is what we were talking about, is that in this particular ventilator, it calculates the tidal volume as the area from here to essentially here. Correct me if I'm wrong, Rob.
Yeah, that's correct. Yeah.
And so
you can't see, but what you've just shown is the zero crossings, right?
right. And so from this point to this point, the tidal volume is unaccounted for because the patient essentially exhaled. And so when the patient exhales, this tidal volume, the exhaled tidal volume, gets added to this, if I'm correct, Rob, and you can correct me.
The exhale tidal volume would be the area under the yellow curve.
Yes.
Right.
And so what happens to this tidal volume that he exhaled? I cannot remember.
It's just not counted.
It's not
Well,
counted.
I'll take that back. It's counted as a negative volume, right?
Yeah.
So if you integrate a positive flow and a negative flow, the negative flow is a negative volume and the positive flow is a positive volume. You add them together, you get the difference. And the difference is not the tidal volume. That's the problem with this ventilator. And what that means is, in a situation like this, the patient, well, not necessarily like this, but in a situation where a patient can exhale during a mandatory pressure control breath, then the ventilator does not display the correct exhaled tidal volume. It could be much less than it really is. So if you're already ventilating at somebody and you see an expiratory tidal volume of say 8 mLs per kilogram, you say, well, I'm still safe. But it could actually be much higher than 8 mLs per kilogram, and you would never know.
Yeah, I remember now. Actually, that's perfect, Rob. So you see the ventilator displays tidal volume exhaled.
Yep.
And it counts exhaled from here to here. And so this tidal volume, if you exhaled here, this tidal volume would be the VTE would be smaller than the VTI, the actual volume that the patient got because he exhaled over here. And so when you're at the bedside, you will only see this volume and you would say, oh, the patient is perfect. And it may be he's getting more, but he's exhaling during inspiration.
Exactly.
And so there's a question here. Do the ventilators deliver fixed amounts of pressure irrespective of the airway pressure at the onset of inspiration, or they just deliver the flow to maintain the target pressure? Rob, that's a question for you.
They deliver as much flow as it takes to deliver the target pressure above, generally above PEEP.
Okay.
It
Thank you,
depends on
Rob.
the mode in the ventilator, but yeah, in general, pressure control means that the ventilator controls flow to give you the target pressure for the duration of the inspiratory time.
All righty. Let's move to the last one. This one actually was a learning experience for me. I mean, every single one of them is, but this was really cool because I learned something that I didn't know about the ventilator that I will share with you guys. So I'll ask the team, anybody wants to read this one? Have no fear. The fellows are here. Okay, I'll read it. And Rob, you help me if I sabotage myself as usual. So the tag for this mode, so you can see actually I'm being cool. I'm putting here. Thank you, Ryan. You're absolutely right. This is PC. Well, you're not absolutely right. There's a little, you need to change one letter in your interpretation. This is IMB to AA. And what that means, there you go. It's pressure control, so the pressure is controlled. It's intermittent mandatory ventilation because actually there's mandatory breaths and spontaneous breaths that coexist. But it's type 2, which means that if there's spontaneous breaths, the mandatory breaths go away. They disappear, they go away. And then it's adaptive and adaptive because it is we have a target tidal volume, and the ventilator is going to adapt the pressure to achieve the set tidal volume that you're trying to achieve. So that's the target. Rob, any comments?
That's it. That is the correct classification.
Perfect. So the load on this patient, actually, you have 3 different breaths here. The first breath, there's an exponential decay. There's no evidence of patient triggering. Actually, the machine is telling you that the patient is not triggering these breaths. However, you can actually see the difference in flow in between the first breath and the second breath. And then the third breath is a spontaneous breath. It's a volume supported breath. It's triggered by the patient. It's a pressure trigger. And then you can see that it cycles by the patient. It was cycled by flow. And then the patient does some weird stuff over here. And then there's another mandatory breath. And actually, you can see right around here that there is, again, evidence of PMOS. So there's evidence of PMOS, and there's no PMOS. So I like this graph because it shows passive. And then even though it's decaying, when you compare it to the other two, you say, haha, something is amiss here. So this patient was having evidence of PMOS during inspiration, but over here, I would say it's exhaling within in a second. Over here, there is actually a long time to exhale, or longer than expected. This patient had ARDS. So I would say there is evidence of PMOS, plus perhaps some resistive component during exhalation, plus PMOS. Rob, disagreements, agreements, or anybody else disagrees?
No, so far so good.
Okay. Aha, yes. The auto mode became active on the third one. That's correct, team. And then it went back to mandatory. Now, I'm still having challenges, and I know Amanthin is on the line, and he will throw a shoe at me, but because I still have challenges on what is the actual guide from the ventilator. How does the algorithm work to suppress the mandatory breaths at what type of rate? And in my classic behavior, I always thought that it was the rate, that if the mandatory rate was higher than the spontaneous rate, then the spontaneous rate would, I mean, if this guy didn't breathe more, then the other one would come in and breathe for him. But it doesn't happen all the time. And so I don't know if there's other overriding algorithm that is sabotaging this.
I think what it is, it looks at the total cycle time breath by breath.
Okay.
So the total cycle time you can see between the second and the third is shorter than the total cycle time between the first and the second, right?
Okay.
So total cycle time is 1 over the frequency. So you could actually calculate a frequency on a breath by breath basis.
So you're talking from here to here.
Yes. And so that got long again. So look, draw the line for the first 2 breaths, and you'll see that they're similar. And from the second and the third, it's shorter. And that's why the spontaneous rate instantaneously was higher than the set mandatory rate. Or in this case, it's probably clearer to say that the total cycle time was short enough to trigger a spontaneous breath. Does that make sense?
Yep. All righty. So let's go over the trigger, because this is thank you, Rob, for speaking up. In terms of the trigger, you can see this one is patient trigger, but there's no evidence of PMOS. But in this one, it's machine trigger, no PMOS, machine trigger, and then there is a hint that I would not have read if I had not seen this one for PMOS. This one is patient triggered with evidence of PMOS, and then this one is machine triggered with evidence of PMOS afterwards. So I think that what you're seeing here is actually a series of early triggers occurring for this patient, and I'll show you some evidence towards that in a second. During inspiration, there's work shifting just because there's activity of the PMOS. It's probably not clinically significant in this case. And in terms of cycle, I actually think that the cycle is pretty darn good in general, even though there's evidence of reverse. I would say that it looks normal. And then in expiration, there's some evidence of PMOS here and evidence of PMOS here. So I'll put expiratory work because that's the dominant feature here. Now, I want to also, a thing that I caught up on, and I want to see if you read it differently, is when the patient was meeting its goal for tidal volume here, everything was good, and then came the pressure supported breath or volume support, as Tim puts there, is pressure support with a volume target. So it's an adaptive targeting scheme. So we move. What I think it does is that when you are on volume support, it remembers how much pressure you needed for the last breath on volume support. And if you go back to mandatory breaths, it will deliver the same pressure that it was using before for mandatory breaths. And that's why there's difference in height on the pressures. Any disagreement there, Roberto?
That makes perfect sense. There's no way you're going to find out without finding an engineer to explain it. Right. But if you had a long enough trail of breaths, you could probably prove it, right?
Mm-hmm. Something that we can do in the ASL.
Well, we can reverse engineer it in the lab for sure.
So I'm going to show you this graph on the last minutes that we have because it's actually this patient, and this is where I learned a fair amount about this. So when you press on this ventilator, the trending function, you're going to get this screen, and essentially you can change the time, the time range for the patient. And you can see, you can actually scroll, and this bar you can move back and forth. So right now it's sitting here, and so it's reading the values at this point in time. So when it says peak pressure at that point is 17 is right here, and the PEEP of 8.1 is right here. And then the respiratory rate, and the respiratory rate is the total respiratory rate of the patient, and then the spontaneous. So if there's a gap, like for example here, this is all mandatory breaths and with a little bit of spontaneous. And over here, because both of them are matching, they are all spontaneous breaths, if that makes sense. And then in the bottom, the same thing, but now with your minute ventilation, you have the spontaneous minute ventilation here, and then they match because the spontaneous and the total are the same. So in this patient in particular, at this period of time over here, the patient was on volume control. And we walked the patient up. We stopped the sedation. And the patient started having those waveforms that you saw at that period of time. So we changed the patient during this period of time. We dropped the rate, and we changed the patient to CMB to AA, so auto mode, volume PRVC to volume support. And you can see that there's still this rate that are coming, those spontaneous breaths coming in, and then all of these this was the mandatory rate. So some of them were escaping through, which I just show you the image. And then we said, well, this is pretty annoying. We don't like what we're seeing. And we dropped the rate a little bit more. And when we changed the rate, we dropped the rate. It was still on the same mode. So this is the same mode, sorry, until here. But we dropped the rate, and it improved, but it was not, there was still an overlap between these two. And then we changed the patient to actually CMB to SS. So exactly the same, but the auto mode is now pressure control. We said, let's just take control over the pressure. So you can see how actually we changed over here. Sorry. You can see how with PRVC and the PRVC and volume support, there's all these oscillations on pressure. And then when we changed to pressure control, we said, to hell with it, we're going to control the pressure. And the moment that we did that, actually these two joined. And it allowed us, now that the patient was getting now essentially all volume support breaths, pressure support breaths. And this is the minute ventilation. And you can see how the patient actually kind of chilled down. The minute ventilation went down, and the team was able to start dropping the PEEP. So it went from this PEEP to this PEEP, and then it went to this PEEP. And the patient was doing fairly well. Actually, you can see how the minute ventilation maintained the respiratory rate. And then we did a major jump because we saw how good the patient was. And actually that led to an increase in respiratory rate and an increase in minute ventilation, indicating that probably they had de-recruited or more dead space had generated. After that, we had to go back up. But the point being is that this trending feature helped us see in a direct way the amount of missed interactions that were happening with the patient, and being able to know in what mode the patient was and how the interactions improved. So with that, it's 2:55. I would ask if anybody has any questions. I will, while we are answering questions, the code for the CME for our CCF team, and see if anybody. So there's a question here that says, is there air trapping from the first breath? The air, yes. So the question is, in this part of the breath, is there evidence of air trapping? And yes, I think that's correct, Satish. I read this one as a passive exhalation. And so this is consistent with the presence of air trapping. And that's why I read this as an increased resistive component for this patient. All righty. Thank you, Miguel. Greetings to Guadalajara, to the good group at Hospital Civil. All righty. Excellent job, team. I will leave here the, again, there are our Twitter handles, our emails. Please send us whatever you want. We love to receive waveforms, and love to see that. So there's a question if this is a missed trigger over here. Yes, Ryan, that could potentially be evidence of effort or relaxation. So good eye. All righty. Have a great day and see you soon.